Welcome back, ATL. We're back in studio tonight. We're really, really excited because tonight we have a guest, Samson, who is going to talk to us about what's going on behind the scenes as it relates to drug addiction, leadership, and community. He's going to be giving us some amazing resources and tips on things that we need to know. Whether you are a parent or a community provider or a pastor, this is a podcast that you want to stay until the end. Samson, thank you so much for being with me tonight.
Yeah, thanks for having me. I'm excited.
Absolutely. Well, for those that don't know you, I do want to formally read your bio so that they know all the great work that you've been doing. We got an opportunity to chat right before this, and you talked about your breadth of experience, not just in Georgia, but in multiple states. And so it's an honor to have you here tonight. So Samson is the Vice President of Clinical Services for Behavioral Health Group. He's an accomplished leader with a history of driving organizational results with learning and development solutions. He's a leader in the field of addiction treatment for over 12 years. He was formerly the Director of Training and Professional Development for NAADAC and National Director of Learning and Development for Phoenix House Foundation. He's a certified lead trainer for the Cognitive Behavioral Interventions for Substance Abuse Curriculum, Calm Every Storm, Crisis Prevention and Intervention. And he's an industry expert in implementing evidence-based programs and practices in substance use disorder treatment programs. Amazing.
Thank you for reading that. I'm thinking, wow, did I do that?
Yes.
I love training people. I love equipping people, so that's probably where that comes from, but yeah.
I love it. And it's interesting because I feel like that's always the response. When people hear their bio, sometimes when you're so passionate about what you do, you're just in it and you don't realize all that you're doing, all your successes and accomplishments.
Yeah, well, I'm definitely excited to share today.
Yeah. So. Well, let's talk about how you got started. To do this work, substance abuse addiction, it takes a very unique person, a person that's beyond passionate, but also a person that's very strong. What's your story and how did you get started?
I guess, so it does take a blend of passion and endurance. So I started by feeling called to ministry. So I started as a pastor in this field. And I remember I started in that way because that's what helped me when I was struggling, as I went through a lot of things as a kid. And I was very fortunate to have a youth pastor, have people in the church that kind of wrapped around. And so that was my perspective of how to help, is to start off in the church. Right. And so that was my journey. And I even got, a bachelor's in pastoral ministries and started off in Alabama with a church plant. And very quickly, I saw that when I would go to people's homes and when I would get a call from them to visit them in the hospital, it was usually because of something that was related to mental health, I distinctly remember a mom who was very involved in our church, had 4 kids, and called me because one of her children had a suicide attempt. Wow. And I remember visiting that home and seeing drugs on the counter. I remember seeing, kind of symbols that I thought we were good. You know what I mean? Like we're in church and what happened? I had no idea, because people put on such a great facade, especially in the South. They go to church and everything's perfect. I mean, it looks better than social media, you know? And they got it all together. Meanwhile, like there's something else going on. So I realized, although I wanted to care and I wanted to help, I don't think I was helping, and I needed to know what was the science of what was effective help and effective care,
Wow. No, it's so many ways to go from here, but I'm thinking about what you said. When you're in church, sometimes people, it looks like they got everything together, and a lot of times people don't like to say what's going on because maybe embarrassment or perhaps there's shame associated with it, that you don't have enough faith to believe God, or you should have been healed that last altar call. Why are you still struggling? Why are you even struggling with that period, right? But what I love is that you didn't come from a judgmental standpoint, but that only drew you closer to wanting to help. But really learning what does it take. As a pastor, I think that is so powerful to acknowledge that.
Even the risk in certain circles in Georgia to say the word science. I mean, just that by itself, all of a sudden people trigger, And it's like, no, I'm actually still a person of faith. I'm still a Christian. I mean, I'm still a leader in my church. But I definitely lacked an understanding in the science of what helps. And what's funny is we question that with mental health. We question that with spiritual issues, with addiction. We don't question that in the medical field. In fact, we're looking for a scientific expert. When we have a blemish to a significant disease, to a headache, who is the expert that can help me today, and how much science do they know, right?
That's right. That's right.
But we don't ask those questions around topics that have a lot of stigma.
Right.
Like mental health conditions, emotional health, self-care, well-being, addiction treatment.
Yeah. I think a lot of it is cultural to me. I also think that a lot of it is lack of understanding. And because there's such a stigma, like you mentioned, associated with these things, people tend not to want to talk about it.
Right.
And so these are the things that we hide and we make them secrets and we're like, don't tell our business. And people much rather struggle. It's almost like, I don't know, what is that? Do you really call it pride? But it's like I wanna hide this because I don't want people to know.
Shame. Yeah.
Shame. Yeah.
And the sad thing about shame is that it's not entirely environmental.
Yeah.
It is biological. I mean, we
Yeah.
all, in a way, are hardwired to experience some sort of comparison. You
Right.
know?
Oh,
And
yeah.
that comparison can breed a sense of confidence and pride in a good way, or it could breed some cover-up and shame
Right.
because I'm not sure how you're going to feel about what you treat me. So then the environmental factors, they just kind of pour flame on the fire, or gas on the fire, right? It's the environmental factors like going to a church that's judgmental,
Right.
being at a school where not everybody looks or acts like me or thinks
Yeah.
like me, being in a community center, a Boys and Girls Club, where
Right.
everybody there is acting and using something, and I don't want to use that, And so you keep being put as you grow up in these different environments, and it can influence that feeling of shame or that
Wow.
lack of control.
That's so impactful. Can you talk about your work in addiction? What do you do, and what are the clients you tend to see and treat?
Yeah, so right now I don't see clients, but my company, we do. So Behavioral Health Group is in 28 states.
Awesome.
We are really focused on outpatient treatment, specifically for the opioid epidemic.
Yes.
And so opioid use disorder has constantly been on the rise, almost doubled in overdose deaths year over year.
Wow.
And the epidemic has transitioned to now being a public health emergency. So Behavioral Health Group really focuses on addressing the opioid epidemic with comprehensive care. So that's counseling, getting folks connected with a community resource, getting them connected with a medical treatment provider, medication-assisted treatment. So we provide that comprehensive care, again, in about 28 states.
Wow.
And although that's what I'm focused on right now, I've also been involved in addiction treatment in a variety of settings. So I've done addiction treatment in the correction setting in prisons. I've done it in school-based programs for kids, community mental health, inpatient, residential, and outpatient.
Wow. So you've worked with almost every population.
Yeah, the different levels of care, definitely. Yeah.
What was it like, the diversity of experiences just across settings in prison versus schools versus community?
Yeah, there's a lot of variety as to why somebody would enter treatment, right? Or why somebody would start using what some people call treatment initiation.
Right.
But what is similar, I think, is even more interesting.
Yeah.
Everyone is trying to kill some type of pain, to cure some type of inadequacy,
Right.
or to give themselves an enhancement in something they think that they don't do well enough, right?
Right.
So they're trying to do one of those three things, right? And at some point, you want to help them find out the root, right? However, in treatment, there's also something we call the root cause myth. Is you could get really distracted trying to focus on the root, thinking, hey, if I just figure out that person that hurt me and how to forgive or how to think about that perspective differently, if I could just find the root cause, maybe this will go away. But that's not the case, So there's a myth that if you dig deep enough, you'll get it. In fact, there's about over a decade of literature review and research that shows that present-focused treatment for trauma-related disorders works equally well compared to past-focused treatment.
Yes.
So you can actually go through PTSD, trauma-related treatment, and not even talk about the past, and have just as much potential for success. The reason is because now you've built up like an environment of behavioral reactions to stressors, to memories. So you could even have a memory that has nothing to do with the traumatic past, and that still triggers similar symptoms of hypertension, hyperarousal, even a desire to use substances.
Wow. That's a very interesting theory, and I'm not as abreast. I haven't practiced in a number of years. I'm also a therapist.
Wow.
But the
Okay, I didn't know
present,
that.
yes, but the present, focusing on the present, which to me it kind of sounds like coaching in a sense. But it's really interesting because I'm thinking about all the unconscious memories that are stored, sort of what happens to them when triggers start to arise.
Yeah.
I guess you learn how to deal with them, or you learn some type of coping skill or response in order to confront the triggers.
Perfectly well said. I mean, in the adult world, we're all coping, right?
Right.
So the question is how do you cope? And which of your coping mechanisms are defense mechanisms, reactive, and you may not have a lot of control over them,
Right.
versus which coping mechanisms do you have that you've created a healthy habit or a healthy pattern,
Right.
right? And so there's a sense where a lot of people with trauma, and I talk about trauma because I don't know there's a way to talk about addiction without talking about trauma.
I agree.
There's so much research that talks about that's where it starts, that there
Yes.
is either someone had trauma and started using substances, or while they were around a community of people using substances, they experienced a traumatic event. So whether it's the chicken or the egg isn't relevant. What's relevant is the outcome. The outcome is over 85% of individuals with substance use disorder also have a co-occurring disorder. The highest co-occurring disorder is PTSD.
Wow.
So
Wow.
when you talk about trauma and you talk about how you can address it, there's a lot of people who are at a phase of coping. Some folks call that safety. And if you're at a place where it's safe to function in society, you're able to have a job, you're able to have safe relationships, you understand what safety is, do you need to go through a phase of what's called reconnection and mourning? It all depends on the person, right? Some people do. Some people need that, and some people continue to pursue that, which is great. That's additional healing, and often requires some experiential healing components, which is not easy, and a little bit more long term. But some folks at that level of safety, they've been able to cope, and coping is good enough, right?
Wow.
And that's okay, right? Because I think that's what makes treatment successful, is that it's wrapped around the individual.
Right. If you can go back, you mentioned 2 stages. I think it was reconnection, and there was another stage you mentioned.
Oh, yeah. So safety.
Can you break those down for us?
Yeah. So safety, in short, most of this comes from Dr. Lisa Nahavitz. She wrote a book called Seeking Safety. And her research comes from Cambridge, Harvard University. It was probably one of the most valid, research studies that was validated in several different communities, including internationally. So Seeking Safety identifies the first phase of safety. Has this person achieved a level where it's safe for them to cope, and it's safe for them to continue with day-to-day activity, right? And that could be, for an individual, could be going back into school. It could be going back into a day-to-day job. It could be functioning within their family, their community. But that sense of safety means they can continue treatment, right? And they can continue pursuing another stage, which is reconnection. And that's reconnecting with maybe a past self, with their authentic self. So, there's a lot of examples I can give for this, but imagine someone who went through a traumatic experience. They were incarcerated, right? And I'm thinking of a specific patient, and they ended up realizing that they were incarcerated unjustly.
Right.
This person picked up addictive-related disorders because they were around communities of people who use, so they started using.
Of course.
They picked up major depressive disorder because they were in an environment where they had no control, and so hopelessness sunk in.
Yes.
They were in an environment where it was increasingly toxic, and so they experienced a traumatic event. So they picked up PTSD. 20 years later, this individual was released because they were a part of a program that reviewed their case and realized they were unjustly incarcerated.
20 years later.
This person went through extensive therapy, extensive treatment. Thank God most of it was paid by the state. And about a year and a half later, they completed Seeking Safety. They completed a safety phase. But he also realized that before he was incarcerated at age 17, he was a doodler. And he was an artist. And he did absolutely incredible art.
Wow.
And so he started reconnecting with that past self.
With his authentic
He started continuing artwork, and his therapist noticed it and embedded art therapy into his work.
I love that.
Referred him to an art therapist, and you're probably going to be able to look him up because his story is nationwide, is well known nationwide. But he completed a very famous artwork that was published in the Golf Digest. Wow. And President Obama and his wife, President Michelle Obama, purchased golf artwork. So if you Google it, I'm not going to tell you the name, but you could look up this artist, but I want you to look up the story that led him to that place, the pain that he went to, that he had to go through to achieve safety, to achieve reconnection, and eventually achieve a place of mourning where in a healthy way he can mourn what he lost, which is time.
That is so, I love the stages, and this is my first time hearing it, so I'm taking it all in, and at the same time I'm thinking about how do we take a model similar to this for communities of color that are dealing with trauma, may not be related to addiction, but maybe dealing with major depressive disorder or social anxiety or suicide ideation, these are the type of kids that we see and treat every day, and I raise. But what we tend to see is like the traditional Eurocentric form of therapy.
Yep.
And what we've been just tasked with is finding new ways of healing in today's era, because it looks very different.
It does.
And I like how you broke down the reconnection with your authentic self. The mourning, like it's okay to mourn.
Yes.
It's okay to mourn the things that have happened.
Some people say, okay, you've gotten through safety, so you feel safe to function. Right. Now you're going to mourning, you've got to feel safe to feel. Because even when you've gone through treatment, certain feelings are frightening. You know?
Oh, yeah.
And you're sitting there thinking, oh, my God, I'm about to get promoted.
Right.
I mean, you almost are afraid of success. You know,
Yeah.
Oh, my God, my side business is now becoming my business. It's no longer a side hustle.
Right.
This pressure is about to be on me. I need to do
Right.
something to find comfort.
Wow.
And so it's because in therapy or in treatment, you may have never achieved an opportunity to feel safe to feel again, you know,
Wow.
and that's a different level of recovery.
That's so powerful. This is so good. And I want to go back to the incarceration point. You talked about a particular client that was incarcerated, and they were unjustly incarcerated, and they went through these layers of major depressive disorder, PTSD. What are people or people that are locked up right now or imprisoned? What are some of the things that you find that they're dealing with that's related to this topic that we're discussing?
Yeah, so we could spend all day talking about unjust incarcerations, right? So instead I'll say, regardless of how they got in there or why they're in there, what do they experience while they're there? And it's a lack of access. And some of the lack of access is inhumane. You know, there are people in prison who were on a chronic medical condition, a series of receiving medications. The second they're incarcerated, they can't get that medication anymore.
Wow.
And it's almost outrageous to think that someone who was diagnosed with opioid use disorder, right? Let's say for 7 years, they were receiving methadone or buprenorphine as a part of their treatment. Depending on the state or the county they're in, they could be incarcerated and not have any access to that medication that was keeping them stable and functioning. Now, are they taking away their diabetes medication? No. You know, are they taking away asthma inhalers? No.
Right.
So then why are medications for mental health and addiction-related disorders not as accessible? Because that's a humanity issue, right?
Yeah.
And unfortunately, that drastically impacts Black and brown people more than anyone else.
Absolutely.
Because these are folks who already had access disruptions while they were in society.
Right.
And now they're in jail, so they've got that access disruption on top, right?
Right.
So we have some states that have made a lot of progress in legislation reform to regulate that better. And in Colorado, for example, in Rhode Island and New York, we can get folks those medications.
Right.
But there's a lot of states like Georgia that unfortunately are still stuck in the past and are looking at those medications as though they are continuing some type of negative behavior, when in fact they are improving that person's behavior. They're helping them maintain stability, which technically would decrease taxpayer dollar on ER visits, on overdose.
Right.
So it is a money savings tactic just as much as it is a life saving strategy.
Yeah, I think you summed it up. It's a humanity issue.
Yeah.
And I'm thinking about why would it happen? Why does it exist? To me, I think it's criminalized. Addiction is criminalized as it's your fault. It's not looked at as this is something I'm struggling with or truly a problem or an addiction. It's looked at as your fault. You can stop anytime you want. When in reality, you can't.
Right.
It is a sickness. And I think it's reframing not just the way we see it, but the way we handle it as a
And
society.
that comes back to your question about community. So, because you were talking about, you know, some of the community programs and the ministry-based programs.
Yes.
They do excellent work, right? But one thing that we've got to do better at a community level and at a ministry level is expand people's perspective of help.
Yes.
Because unfortunately with mental health, and we talked about stigma too, right?
Right.
But with mental health and addiction, opioid use disorder, that stigma already makes somebody feel like they're alone.
Right.
Which is a little bit crazy because the data we know says there's 7.8 million people with the exact same diagnosis, right? So when you look at the data, you say, oh, how can you feel alone? You're one of, you know, close to 10 million, right, with that diagnosis. But that's how the symptoms feel. That's how they emerge, and it is very real. It's not something that's fabricated.
Right.
So you have a disease that pushes you to feel isolated. You have a society that says, hey, you can only get help from me, you know? And here, let's fill in the blank. You can only get help from your pastor. You can only get help from someone who else is dealing with addiction. So you got to go to AA, you got to go to NA, you got to go to sober sobriety. You could only get help from an abstinence-based program, not a harm reduction program. There's all of these limiting type of statements that we keep in our circles, and we think we're doing something righteous, but what we're doing is we're trapping someone in a corner when they are in a crisis, they're in a need. So the best thing you can do when someone comes through a ministry or a community-based program is work hard to expand their perspective of help. Make sure they understand they can get help from anywhere, you know? And later you want to talk about safe, people versus unsafe people.
Right.
But get help from a doctor, get help from a nurse, get help from an ER, get help from a social worker, go to a church, that's fine. Go somewhere where somebody can hear you out, because that's a lot better than what isolation can do.
Oh, yeah.
Which can turn that mental health or that addictive related disorder into an instant mortality, right?
Yes.
And in many states, they've embraced harm reduction principles and strategies all the way up to safe syringe exchange programs or safe use sites where someone can use substances in the care of a nurse, right? And in the care of someone who is considered, medical personnel. Right. But you suggest some of those things in some of our states in the South, and they are just losing. Like, what? How could we do that here, right?
The world is evolving. Treatment has evolved.
Yes.
And our society, our systems, our government, our policies must reflect what we need, what the population needs. And it's going to take a lot of effort, like what you're doing right now, and also bringing people in those decision-making seats to make those changes. There are certain people that need to be there that have the lived experience, or at least have the understanding to make those policy changes. And I think that is where a lot of the gaps happen in terms of policy.
Yeah, a good example of that is the opioid use disorder settlement funds. So every state received a certain amount of dollars for the settlement with Big Pharma on how they initiated and kind of played a big part in the opioid epidemic, right? Now, how those states are using those funds seems to vary widely, and you will see some states appropriate most of those funds in more of a campaign, where it's a fear-based campaign or keep your prescriptions safe, which is good. I mean, prevention is really important, but we're talking about prevention in a community that's already been using for 7 years. So what are you preventing? What they need is they need access to care, they need treatment, and that care needs to be in their community. It can't be something that's inaccessible. For kids, the care needs to be in the school, right? For those who are incarcerated, the care needs to be in the prison, right?
Absolutely.
So that's the challenge, is where these funds are being allocated, misproportionately, and they're not being allocated in communities that need it the most.
Yeah, we need accessibility. So we need to, and a part of that is when you're talking about funds dispersed, there's a bill or amount of funds that went towards opiate treatment, but there's really probably much going on. A lot of that is what's happening when it hits whoever those government officials are. When it hits them, what happens after that? There has to be accountability. And that's one of the things I think that government struggles with greatly. But I want to talk about two last things.
Okay.
One is if you can talk about what drug addiction looks like in families and how it impacts families. And then lastly, advice to just community members, family members, and pastors and ministers on how to address this, or what the science of help looks like.
Okay. Okay. The first question. Is what does drug addiction look like in the family? So there's a few different ways to address that. So first, I'll start with kids, right? When kids start using, which, by the way, from age 7 to 17, the National Survey on Drug Use and Health has shown that every 2 years, substance use from age 7 to 17 has more than doubled in the last 10 years. So every 2 years, it's more than doubled. And yet, there's been a lot of effort towards teen intervene, prevention, strategies, DARE campaign, which was ridiculous. And there was a whole lot of all these campaigns to stop something that was already happening, right? But the data was showing us that kids are already using at a very, very young age. So the first thing is to look at that as a sign or a symptom that whatever is happening in the family or in the community is not working. Now, we can't interpret that as, these kids are using because of their family or because of the home. That's not always the case, right? They could be. But that's not always the case. More often or not, what it is it's a symptom that's saying, hey, alert, whatever we have in this environment is not meeting this person's need.
Right.
You almost want to look at that teen or that adolescent using substances like a flare-up in your own physical health symptoms when you turn a certain age, right? And so as you grow up, your body's going to send you signals.
Oh, yeah.
You'll start having headaches or you'll start having physical pain.
Yes.
Usually your body is telling you, hey, whatever is your diet, whatever is your physical exercise routine, that's not working.
Right.
It's not saying that it's causing it. I mean, it could be, but it is saying that here's an alert, something's not working. So the best way to address someone within that age range is to start with the system, the environment, assess the community, assess what's going on in the house, in the family, assess what resources or what community involvement that child has, because that very well could be exactly where the solution is.
Wow.
You really start seeing a lot more success in individual therapy when someone gets older, right? But at a younger age, we're sitting here trying to fix a kid that some family has thrown at us, you know? And it's like, hey, you know, I could
fix
teach
them in 2 months.
That's what they want, right?
Yeah.
And it's like, hey, I can, right? I could try and teach them a bunch of strategies, but it's not going to be sustainable.
Right.
Because they're going to keep getting placed in an environment that either induced the symptoms to begin with or contributed to those symptoms not being addressed, right?
Right.
So what it looks like in the family, that's kind of the first thing I always say.
Okay.
Most family intervention models, like multi-systemic family therapy, functional family therapy, they were designed around treating the system, and they have the highest rates of success year over year.
Yes.
So there's a reason for that, right? The other part is generational, right? Is that people tend to cope with things the same way previous generations did.
Right.
So that is a much bigger topic. I would never try to tackle that in a short amount of time. But I would say there's something to it, right? There are a lot of studies in genetic predispositions to use substances. There are a lot of studies in certain environmental factors where substance use being normalized can make it a lot easier for someone to start using or to do what's called treatment or substance use initiation, where they start using because their uncle uses, because their cousin uses, because someone in the home uses. And I grew up in a generation, in a world where for my family, we were immigrants. My family's from Ethiopia. It was very normal to invite some stranger into the home and say, hey, that's your uncle, that's your cousin. And really what it was is somebody needed somewhere to stay, you know? And so there was an open door policy, but we don't think about in our community how that can affect the next generation and who we're bringing in and how are we elevating the idea of safety over, letting people in our doors, right? And so my cry is, okay, let's look at this. But my praise is I think our generation is doing a lot better.
Absolutely.
I'm noticing this generation of parents, they're not just letting anybody come in the house that, you know? And it's like, yeah, we know our community needs help, but we know where to point them to, and where to make sure that folks get help they need, but also protect our most precious, valuable item, which is our kids, our next generation. And so hopefully I kind of wrap that up on one, but I forgot what the second question was.
That was excellent. Thank you for that. If we, in closing, can talk about pastors, ministers, community members, how do we come together as a village to really tackle and confront this head on? Yeah,
it starts with what I was saying about shifting the perspective of help, As a minister, you may not even know that you've restricted what you think is help. You've said, Jesus is the way, and I'm a person of faith. I do a ministerial leadership training, and I'm very, very passionate, especially in my personal life, when it comes to getting people the right help and even getting them into church. But I would never say that that's the only kind of help out there, And I would never say that that's all encompassing, because I know when someone gets sick and when someone has cancer, they're not going to pastor. They're going to pastor after they checked in with the doctor and after they got a second opinion and a third opinion, right? And so they're quick to seek scientific help. But when there's a mental health condition or when there's a pattern of thinking that it seems like praying it away isn't helping, ministers have to realize what they really care about is that people get help. That's why they're in the field. Nobody goes into ministry without having a desire to help people who are suffering, right? So my encouragement is tap into that raw desire to help people who are suffering and expand your perspective and your connectedness with help. The best pastors in our community right now, in their office, they have a list of resources that are within 15 to 20 minutes, right? And they should have that list right on their wall so that people know you can get this kind of help here. If you have an eating disorder, here's a community program for that. Here's a counselor close by that will see you for issues related to womanhood. Here's a counselor that will see you for issues related to race, for issues related to masculinity, for identity, for belongingness. Whatever it is that people have pain with, you should have that list of resources.
Wow.
Just like you know the Word of God, you better know the Word of your community.
Oh,
and,
that was
and be
powerful.
connected with
That was
exactly where people can get help.
Right.
I think that's where it starts, is to tap into that passion to help people, because that is a good thing. There's nothing wrong with that. I think we just don't want to limit it. We don't want to say, hey, only go here, you know.
Right.
And I even have relatives that will ask me for referrals, and the first thing they say is, hey, I'm coming to you because you're a Christian. Can you tell me about a Christian counselor?
Right.
And I'm like, listen, okay, I could, but you got to drive 45 minutes up north. Do you want a counselor that's 5 minutes down the road that you will go to after work every day?
Right.
Because at the end of the day, that's what you need. You don't need a Christian counselor. You need a counselor, you know? And be careful of limiting or restricting the different ways that you can receive help, because the only thing you're doing is harming yourself, right?
Yes. Oh my goodness. That was amazing. That was incredible. And we're closing, but I got to say that, you know, this is in its essence what it should look like to do ministry. And I think you mentioned it. You went into pastorship. You had a passion for helping others, and then you ended up being led on another pathway, still helping others, but in counseling. So what would it look like if ministers and pastors, maybe they do have specialties in certain areas? Ministry is obviously the area, but where at in ministry? Where at? What does help look like? Are you called into addiction? Are you called into pastoring and ministering to those that are in shelters and homeless or incarcerated? But I believe that what you said is so impactful and powerful, is that we don't get into this in ministry because we don't want to help people.
Right.
Get into this because most of us have a story and feel a call to help those that are suffering.
Yeah.
So I really do hope that those that are listening, whether you are in ministry or not, that you really consider the words of Mr. Samson here, because I do believe that this is what help looks like today. We have to re-engineer. I've been using this word a lot. Ooh. We have to re-engineer what help looks like, especially in our community.
Yeah, I love that.
I think that's the way to heal our families.
Yeah. Good way to say it. Yeah, and I'll just add one last thing is in Georgia specifically, in our state, we perceive harm reduction, methadone or buprenorphine treatment, as something that is continuing a person's pattern of use. But what it's actually doing is keeping someone alive long enough to get the help they need, right? Wow. So when I say expand your perspective of help, I mean also understand that help is not always an event. Right. Sometimes help is a journey, right? Oh, yes. So what kind of help someone can get to stay alive long enough to get into recovery, to stay into recovery, that is just as important as some magical, curative snap of a help, right? Oh, yeah. Which, by the way, is more the exception than the norm. Right. Most people are on a pervasive, chronic, relapsing disease, and they're starting and stopping in recovery. Yeah. But where's their thread? Their thread of a safe, affirming voice, a safe, affirming, listening presence, a friend, a parent, a community member, someone who at least has an open door policy to say, hey, I will listen. I may not have an answer for you, but I will hear you out. That by itself, just like methadone, buprenorphine, just like someone taking medication for ADHD, and by the way, there are non-stimulant medications, so it's not just stimulant-based medications for ADHD, but those are ways to keep people stable and functioning long enough to get to a place of full recovery where they don't have to lean on something. And by the way, if they do that for the rest of their life, thank God it extended their life.
That's right.
Because what we're dealing with is an overdose epidemic where people are dying at alarming rates because they're being trapped in these corners of only getting help from one way and one place. Yes. But there's so many different paths to recovery, to healing, and to help.
Absolutely. That's so powerful, Mr. Samson. We got to bring you back on.
All right. Sorry, I could talk all day.
That was so good. It is really about saving lives. Yeah. And this is personal for me. My father died of an overdose. Wow. So very personal. So I'm taking it in and I'm saying, if only he had a program like this that could really help him. Because
I hear that so often. I'm so sorry for your loss and for the memory that you have to hold on to, But I could see how that pushes us. I can imagine there's thousands of people out there with that story. Oh, yeah. That folks passed in a time where something was not accepted, where there were not multiple paths for them to choose from and to access. And where treatment, like you said earlier, you talked about diversity, you talked about communities of color, treatment was primarily Eurocentric. So even when folks would go in, it wouldn't work. Because it was not designed for our perspective, folks. For our mentality. There was not expression arts. By the way, you know, side note, expression arts therapy has been on the run in counseling because of the success rates we see in Black and brown communities. Yes. Communities who have felt a history of oppression, they need to express. Yes. And that is a part of how they can find liberation. Mm-hmm. So tapping into their raw, instinctive intuition to express, helping them find that voice, that is a powerful part of treatment that has been underutilized in Eurocentric models.
Yes, absolutely. And we've always healed that way, honestly. Yeah. We've sung, we've expressed ourselves through arts. It's embedded in who we are as a people. And so tapping into that, it only makes sense to helping our communities heal. So this is amazing. We are closing. Y'all, this was so powerful and inspiring. It really warmed and touched my heart. The information, hearing this from you, Mr. Samson. How can people reach you if they want to follow you or get in touch with you?
Yeah, good question. I wish I thought about that before. I would say find me on LinkedIn. You know, so there's probably not too many Samson Teklemariam spelled the way you may see in my bio. But I'm very active on LinkedIn. Please feel free to connect with me. You can also find me by going to Behavioral Health Group, learning about Behavioral Health Group, or NADAC, the Association of Addiction Professionals, two large national organizations I'm very involved with.
Excellent, excellent. Thank you so much, Mr. Samson, for being with us. We got to bring you back on.
Thank you.
It's been amazing. It's been incredible, very resourceful. This information we want to get to our communities, whether you are a parent or you work with kids or you work in the field or you don't. We want to make sure this message is elevated and amplified. So do us a favor and share this out to your family, your colleagues, and your networks. We appreciate you all for being with us. We love you all so much. We'll be back next time. Stay tuned.